Hello everybody and welcome to this session. My name is Hildegard Theobald and I am the chair of this session. I am professor of organizational gerontology at the University of Fechter in Germany. My main research areas in the area of long-term care. I'm doing international comparative research on very different areas. This session is one of the 4 sessions related to the theme 5, which aims at analysis and discussion of sustainable care at home with a focus on the development of the care mix. In this session, we will discuss situation and the role of informal carers within this care mix. Now I would like to introduce the first speaker, Petra Ulmanen, to start with the conference. Petra Ulmanen is an assistant professor at the Department of Social Work at Stockholm University. Her main research areas are care, welfare state, and gender, and she's primarily focusing on family caregiving for older persons. She looks at the effects of organizations and of health and social care services and its social and economic consequences. Now I would like Petra to start with her presentation.
Thank you, Hildegard. The title of my presentation is Realization of Aging in Place Policy in Swedish Eldercare, Consequences for Family Members as Informal Carers. And I'm going to present some preliminary results from an interview study with family members of very frail older persons in Sweden. Next slide, please. In Sweden, we've had, like in many other countries, a deinstitutionalization trend, and I think maybe it has been particularly strong in Sweden. Since the early 1990s, the number of hospital beds has been reduced by more than 50% in Sweden, and today we have the lowest per capita hospital bed rate in Europe. And since year 2000, the number of nursing homes beds has been reduced by over 25%. Today, 4% of the population 65 years and older are living in nursing homes. The decline in nursing home has been more dramatic in Sweden than elsewhere, and it has not been compensated by increased home care, especially not regarding the intensity of care. This has resulted in a shorter average length of stay in hospitals and in nursing homes in Sweden, which imply that an increasing number of older persons with extensive and complex care needs are cared for at home. Next slide, please. Also in Sweden, we've had some organizational changes in home care services, which make it harder to meet clients' needs. It's about increased standardization and fragmentation of home care work, which causes staff discontinuity and limits job discretion. And this, in turn, limits care workers' capacity to meet clients' needs. We have an increasing number of clients who receive many short visits by a high number of care workers. They make on average 15 visits to 12 persons per day, and more than half of the visits are 15 minutes or shorter. And home care clients who have at least 2 visits a day, they meet 16 different care workers in 2 weeks' time, on average 16 different care workers in 2 weeks' time. Next slide, please. And this development has made me especially interested in a special caregiving role, informal caregiving role. It is when family members are like acting as care managers. They are like informally providing what is called managerial care. And this has received limited attention in social care research. But we've had some attention, and like Archbold in the 80s described this kind of caregiving, that it's about to identify needed services and manage their provision by others. And Brody later on defined it as identifying what services are needed and if they are available, gaining access to and mobilizing services, and monitor and orchestrate services. And this implies an overall responsibility. It's about ensuring that care is provided at the appropriate time and in a way that is acceptable to the cared for. Next slide, please. And it has been discussed in the literature, the so-called structural caregiving, that this kind of managerial caregiving may imply some burden, and this kind of burden of negotiating and managing long-term care services has not is under-recognized. And that the complexity and the fragmentation of care system increase this structural burden. Next slide, please. And I think that the development we've had in Sweden imply that managerial caregiving has become more common and increasingly important. As eldercare coverage is still comparatively high, a majority of family carers in Sweden, they share their commitment with public services. And we've had a development that services become less available and more fragmented. The need for managerial care increases, and this task becomes more challenging. And that's why I'm interested in this particular task. Next slide, please. I've done an interview study, pre-COVID interview study, with family members, mostly adult children of older persons in Stockholm County in Sweden, with extensive health and social care needs. And I had like 3 main questions. The first is, how do they perceive the ability of health and social care services to meet their parents' or partners' needs? And 2, how are their lives affected by the performance of these services? And 3, how do they perceive managerial caregiving? And this is a study with a longitudinal design. I've done repeated interviews during 1 or 2 years, and I've interviewed 55 persons, 36 women and 19 men, and more than half of this group has been interviewed twice. And I have in total around 100 hours of interviews, and the results I'm going to give you today are only preliminary. Next slide, please. Some preliminary results about the first question about the ability of care services to meet care needs. Well, the family members that I have interviewed, like most, are satisfied with the care provided at hospitals and nursing homes. They are not very, generally not very satisfied with home care services. They perceive that there is a lack of continuity, and they don't really trust services. Many think that too many people are coming and going, and the visits are too short, and there's not enough time to provide proper care. These family members, many feel that the situation is not safe at home for the cared for, and they are going repeatedly in and out of hospital. And some of them feel that nobody is really taking the main responsibility. Many interviewees say that it is too hard to get a nursing home bed. And those that I have interviewed who help somebody who lives in a nursing home, they mostly perceive like continuity of care, and they mostly like trust the care services giving at nursing homes. Next slide, please. And some preliminary results concerning the second question, how are family members affected? Well, regarding home help services, home care services, well, many feel a lack of trust. and there is not enough continuity of care, and this increase worry, feeling of responsibility, and the need for managerial care. And regarding nursing homes, most trust the care services given at nursing homes, and they perceive continuity of care in nursing homes, and this implies less worry. They feel they are not as responsible anymore, and they feel that there are almost no need for managerial care anymore. And the move to a nursing home is described by many family members as a great relief. They don't have to feel as worried anymore. They don't have to take as much responsibility anymore. And they feel to a greater extent that the cared for have a better life situation. It's more safe, and the care services and help and assistance is closer, is in the building, very more close to the person. Next slide, please. When I've been trying to understand the discontent with home help services or home care services, I think it's about, like, today it's harder to get a nursing home bed, so like problems caused by discharge from hospital, like quicker and sicker, then becomes a home care responsibility. But home care services, they generally lack the resources and organization necessary to assume this responsibility, because of this decline in nursing homes, home beds, that has not been compensated by an increase in home care, and also because the organizational changes in home care services that makes it harder to meet complex and extensive needs that I told you about earlier during this presentation. Next slide, please. In my analysis, I've been trying as a first step to identify, to describe what are the family members really doing when they are, what is managerial care in my material. And I've been starting from broadest definition to try to identify the managerial caregiving roles in my material. So broadest definition is a definition in a process in 3 steps. The first step is in identifying what services are needed and if they are available. And the second step is about gaining access to and mobilizing services. And the third step is about monitor and orchestrate services. And regarding the first step, identifying what services are needed and if they are available, I call this role the navigator. The navigator collects information on how to navigate the system. And in the second step, gaining access to and mobilizing services, I call this role the representative. And the representative speaks for the cared for. And we also have a second role here, the coordinator, that passes over information and negotiates between actors in the care system. And the third step, to monitor and orchestrate services. Here we have the watchdog that watches over the actual service provision, and also the representative and the coordinator is relevant roles in the third step. Next slide, please. And when those roles are not enough to make things work, to make care services work, to meet the needs of the cared for, the family members, they kind of step up and intensify and change the strategy. And when the coordinator role is not successful, they change to the project leader role instead. And the project leader intensifies the orchestrating of services. The project leader takes an overall responsibility for organizing services. But this is a project leader that is unwanted and without a mandate. So, and that makes it a really hard role to assume. And when the representative and or the coordinator are not successful, the negotiator role is used. And the negotiator uses like a more systematic strategy in trying to negotiate with the system. And when this negotiator is not successful, the fighter pilot comes in and uses like a more like aggressive and uncompromising strategy in trying to fight the system. Next slide, please. And about my third question, how the family members perceive this managerial caregiving, I've had identified some challenges in managerial caregiving in my material. I see like they assume a heavy responsibility, but they have very limited knowledge and they have very limited control. Regarding like how the care system works and the parents and partners' needs, and also regarding the best way of satisfying them. So many of the family members, they are like disappointed in home care services, and they don't really trust the care system. And that of course increases responsibility and also the need for knowledge and control. And I've been thinking about this job stress theory of Karasek and Theobald, that the job demand control model. It is the combination of high demands and lack of control that causes like negative stress at work. And I've been thinking about maybe using that. Next slide, please. I've also identified some specific challenges in my material for women in providing managerial care. I think that women are like more, or seem to be more burdened by handling contacts with care services, and especially concerning making demands and complaints. Only women in my material, none of the men, say they do not want to be a nuisance. They say, I don't want to be a troublesome daughter. No man says that they don't want to be a troublesome son or husband. And most men do not perceive making demands or complaints on care services burdening. And when I ask them more about that, they refer to their professional role, like experiences that they have used in their professional role. They have developed like professional skills about like negotiating and so on. And they think, well, it's the same thing I'm doing at work. It's not a big deal. And some of these men think that they are good at it also because they have been really developed this skill and used it a lot at work. And also women in my material, they use professional skills from their work, but they use kind of a little bit in other ways, and also like different skills, because it is women that work in the care sector that talk about like they're using professional skills in their managerial caregiving, and they use them to like they have this knowledge about the system, the care service system that they can use in order to navigate the system in a better way and trying to access services. They know what to ask for and where to ask for it, and also to some extent to negotiate. Next slide, please. I've been trying to understand these gender differences in managerial caregiving challenges in my material, and I've been asking myself if men are better negotiators or if they meet less resistance when they're trying to negotiate with the care system. And if they meet less resistance, it means that women's requests are taken less seriously by the care system. And I've been asking myself also if women form like higher standards and demands regarding care because they meet stronger expectations to provide care and to be good at providing care. And if women therefore feel more responsible for meeting care needs, which make them take on the more like burdening parts of managerial care to a greater extent. In this way, managerial care is just like any other caregiving task. This is just another way of assuming a greater care responsibility, which we have seen in caregiving research that women often do. Next slide, please. I've also been thinking about using this doing gender approach, that men maybe are doing masculinity by being a successful negotiator, while women maybe are doing femininity by maintaining high care standards. And I think that it must be harder to be a successful negotiator if you have high standards. This was the end of my presentation. Thank you very much.
Thank you very much for the very interesting presentation on the change in the managerial role in Sweden. Now I would like to come to the second presentation. The second speaker is Masa Filipovic Hrast. Yes, I would like to introduce you first. Masa Filipovic Hrast, I hope it's correct, is an associate professor at the Faculty of Social Science at University of Ljubljana in Slovenia. She's a member of the Sociology Department and researcher at the Center of Welfare Studies. Her research topics include social policy, social inclusion, and aging and care policies. Now I would like you to start with your presentation.
Thank you very much. My name is Masa Filipovic Hrast, and today I will present a paper on based on qualitative research that takes a life course perspective, looking into why certain people become carers, and this is based on data that we collected within two countries, Austria and Slovenia. This is a work that is based on our collective project, and my co-authors are Ricardo Rodruiges, Selma Kadi, Valentina Hlebec, and Miriam Cerar. Next slide, please. So, to start, why we chose a life course approach. Life course approach captures the complexity of caring trajectories and sees caregiving in a dynamic perspective. And it is still relatively underexplored in how early life trajectories link with caregiving in later life. So one of the key aspects of life course theory is that they are marked by sequence of life events and transitions. And these trajectories are interconnected and can form a path dependency. Therefore, pathways into informal caregiving are part of this cumulative process associated with prior life events and choices, where path dependency plays an important role. And this has been already partly shown in some of the research. For example, the differences in economic resources and health and well-being well before the first episode of caregiving are associated with different patterns of informal caregiving observed in later life. Next slide. So the study, as I mentioned, uses qualitative data. We collected semi-structured interviews with dyads, so older users of home care using formal and informal care, and their adult children providing informal care. This was carried out, I think this is something that we will all now need to mention, in a pre-COVID period in 2019 in Austria and in Slovenia. And the sample includes a total of 76 dyads, so 152 interviews from both countries combined. and they were purposely selected to reflect the diversity of sex and social class. So we wanted to focus on the factors leading to the choice of care mix within a heterogeneous group of families. And in this particular part that I will present today, we focused on the choice of becoming an informal carer. So this was only a part of the whole study. Next slide, please. So to give just a short presentation of the demographic characteristic of the carers and the older people receiving care, as you can see on the slide, we have a mix of genders, especially among the caregivers. We were very happy to also get quite a significant amount of male caregivers, almost 40%, while in the cared for person, the majority is still women. Then we have the mix of socioeconomic statuses, so from low, middle, and high socioeconomic statuses as within the caregiver group as well as the cared for persons. And for the age of the caregivers, we focused on children, daughter or son-in-laws, or grandchildren as as the main caregivers, so not on spousal carers. And we see a mix of age groups in this among these caregivers, and within the care for person, we have people approximately 60 plus, with a significant share of those aged 84 and above. Employment status of caregivers was again mixed, although majority was full-time. Some of them were part-time and some of them retired. And there was also a mix of living situations. Next slide. So within our framework, we identified three main components of life course approach. So we focused on transitions, the cumulative processes, and the linked life events as the three main determinants of these pathways. And within the specific transitions, these are certain bookends of life stages, we could say. So these are more abrupt changes in someone's life. For example, divorces or early exits from the labor market, which all have the potential to shape life trajectories and put people into a pathway that facilitates, for example, caregiving at a later stage in life. The cumulative processes are linked to the carer's life and are related to more gradual, more long-term processes in someone's life story. In particular, for example, the intergenerational relationship within the family. So these may be embedded into wider reciprocal family exchanges within kinship relations, in marking this interdependency that is characteristic for the families. And then the linked life events as a special component is linked to the life trajectories and individual welfare that are linked to the choices, resources, and transition that other individuals have and are related to the observed care dyad or care, mainly caregiver. So we focused on these components in our research, but we tried also to incorporate the context that underpin the caregiving. Next slide. So we identified in our analysis 4 pathways to care, which are actually not mutually exclusive, but they emphasize specific components that we identified in our framework. So the first pathway is related to these turning point events in life. These are chiefly specific key events in someone's life course that had an important impact on their current situation and their becoming a carer. So these included examples such as divorces or specific changes in habitation, for example, moving in back with the family. Or late moving out from the family, and this all affected their relationship to the care receiver and affected their being a primary caregiver at this stage in life. So here are some examples of the citations or the quotes. For example, one is from the Austrian case. She said, "Why I am the youngest, was at home the longest time, and I'm involved in almost all of the decisions, have been almost everywhere, jointly responsible regardless of what was done." So this is linked to this late leaving of the home. And then there is a Slovene example of, for example, the separation, how this affects. Yes, simply wife and I separated. I used to work here and had only basic wage. If you are alone, you're struggling. Until it was two of us, there was no problem, but then you're alone and you have to pay. So this was the reason they moved back with their, this person moved back with his mother, while she was not in need of care, but of course was already available care at the later stage when the need arose. So next slide. These were the pointing turns, turning point events in life. The pathway 2 is linked to a more cumulative processes in someone's life. And these are linked primarily to the labor market. So, for example, one characteristic of this pathway is that there was accumulation, for example, of disadvantages, such as history of weak labor market attachment, which resulted in this person being the designated carer within the family. This specific case from an Austrian female caregiver, where she said, "I have to say, my was classic woman's employment in Austria, 2 part-time jobs, but my mother isn't to blame. This just resulted from my biography. If I had been with children, then it would change her situation." So we see that this weak labor market attachment for this woman, and there were several cases like that in Austria as well as in Slovenia, resulted in them being the one that took up the care for the parent. And then one interesting also, which we turned within this, labeled within this cumulative process pathway linked to labor market, is the accumulation of caring experience that related to professional life. And it's again something that was linked more to the female caregivers, which have been by their profession caregivers. So when they there was a need for caregiving within the family, they were the natural choice as the caregiver. For example, they were previously employed in a nursing home as a nurse, and so I was called on to provide care 3 times a day, 7 days a week. So this was a natural link to their professional life, and it seems to accumulate from their experience, caring experience in profession. Next slide. So the next pathway is also related to cumulative processes, but it is linked to continued and sustained exchanges of support within the family. So many interviews refer to a history of exchanges within the dyad that generated kind of a moral expectation to reciprocate with the informal care. So this is the accumulation of interchanges of support within the family that resulted in this expectation that also in this case, when the care was needed from the parents, they kind of returned. So, and this was not necessarily linked with very close relationship, although it was characteristic. For example, one side said, I would say we had a normal relationship, nothing particular, linked enough, I think. So parents helped in beginning, also financially, and to me and my brother, and I guess we are returning this in a way. What is interesting also is that this pathway was more linked to middle and high class carers, while, for example, the previous pathway was more linked to the lower income of carers. And here the gender specific was not as pronounced as, for example, in previous pathway. Next slide. So the last pathway is linked with, labels the linked lives and shows the impact that life trajectories of others have on the carers and their pathways into care. So it reflects the cases in which individuals became the carers because others were not available within the social network of potential carers. So there were different types of unavailability within this social convoy of care. Either it was due to previous family conflict within the siblings or between the parent and the other children. The health issue of the siblings, demanding jobs, family situations, and so on. So there were different reasons why the other siblings were unavailable and the majority of care was left with the person caring for their parent. This is one example. I have work, my sister is ill and cannot help. She's 3 years younger, but she has multiple sclerosis. So here the health issue has been most important. Next slide. So to conclude, we identified, as I said, 4 non-mutually exclusive pathways into caregiving, which have indicated also that some transitions can trigger their own path dependency processes and can also present kind of a gravity pull toward disadvantage. And they act as accumulation of potential exclusion or potential difficulties. For example, due to interrupted careers or weak labor market attachment, this facilitated the transition into a caregiving role, which is again, for example, especially in cases of Austria, where there is a supported familialism. This is again a precarious, often labor market situation with low protection, and in Slovenia even worse. Due to not being very well supported family care system. The pathways also indicated that within the caregiving, there are still reflected these gender life trajectories and transitions. And we feel that this has important also policy implications that we'll need to look also at how the policies can affect caregiving, not only through the caregiving policies, but earlier life stages, and how they may stimulate accumulation of disadvantages, and this should have a special attention. The last slide, please. So, of course, we have also some limitations. At the moment, what we presented is a common study, but of course, a more detailed exploration of these country differences based on also institutional differences of the 2 familialistic countries of Austria and Slovenia, which is a common background, but with slight differences one being supported familialism, such as in Austria, but in Slovenia unsupported, has not been the scope of this presentation, but is very relevant. We also had a sample of carers, informal carers using formal and informal care at the moment, which might be generating potentially specific pathways. Also, what is interesting is that care cultures and institutions, of course, are not statics, and this is partly also illustrated by our data. And caregiving may well vary across different cohorts. And we have also focused only on children carers. We have not looked into the spousal care in later life, and interrelationship of these pathways. So spousal and children cares would add, of course, additional insight and would be relevant to look. And I thank you all for your attention, and I end my presentation here.
Okay. Thank you very much for the very interesting presentation on the pathways to informal care in the two countries you have analyzed. Now I would like to come to the third paper and introduce Nora Keating as a speaker of the third paper. Nora Keating is a professor of rural aging and chair of the Center of Innovative Aging at Swansea University, but is also professor of University of Alberta in Canada and Northwest University in South Africa. With her theoretical empirical research, she challenged scientific discourses, contributed to the developments, and influenced policies in global social and physical context of aging. And as director of capacity building, she is a member of the leadership team of this research program, Sustainable Care, Connecting People and Systems. And I would like to ask Nora Keating to start her presentation.
Thank you, Hildegard. It's a pleasure to be part of this session today. My presentation is going to speak to questions about both informal care and formal carers, but thinking mostly about how care might be seen as sustainable and what sustainability would look like. It's been my pleasure to work with both Alistair McGregor and Sue Yendall on this paper and throughout the program. I think this work is an interesting example of how collaborating with people across disciplines really can help you think differently about your work. Alistair McGregor is a political economist, and his work on the Sustainable Care Program has helped us think about what we mean by well-being of people who are providing care. Sue Yendall's work in care and care policy has helped us think about how we place this work on broader country and policies agendas. Next slide, please. One of the reasons that, excuse me, that we are interested in this work is this very long-standing concern in many of our countries about how we have increasing needs for care and yet insufficient capacity, both fiscal and human, to provide the care that's needed. As you'll remember from Petra's presentation, I think one of the points she made very clearly is that we've been talking about these things for a very long time. And one of the things that's happened during the pandemic is the tensions around providing adequate care and really respecting the dignity both of people receiving the care and of those providing it has been sorely challenged. Our work then is in an attempt to be hopeful, to think about a new approach that is gaining some traction, and that is to talk about well-being and where we can reduce the failures in well-being that we see among both family carers and care workers. Next slide, please. The question we ask then, and is one that's being asked around the world, is what would make care sustainable from the standpoint of the people who provide it? The big shift here is that much of what we've talked about for many years in terms of um, responsibility for care has been in economic terms. We look to GDP, we look to productivity. This shift suggests that well-being improvements are the ways in which we should measure how well a society is doing. Next slide, please. The new understandings of well-being, and this is work that McGregor has brought together during the Sustainable Care Program, suggests that we need to look at three elements of well-being if we're really to think about who's doing well and ultimately how care will be sustainable. The first of these is what the person has, their material well-being, often in families around what are the costs they assume to provide care, often with care workers, what is the minimal cost they will accept in order to do their care work. Relational well-being has to do with the ways in which one's relationships might help you continue to do your work. And with families, it's often based in their relationships with others, as Masha has said in her presentation. With care workers, often these relationships are not well understood. And finally, how do people feel about what they're able to do given these resources? In our view, well-being is a necessary precursor to care being sustainable. Next slide, please. I want to tell you briefly about the work that we've done, which is preliminary in that what we did based on this framework is to look at the research literature to try to determine what we know about these various costs for family carers and for care workers. Clearly, a next phase is then to think about how do we measure these and move these into questions of sustainability. There's a good bit of literature on the material costs incurred by family carers, often related to giving up labor force or to truncating their education if they're young carers. They have implications for lost income and other benefits. And many carers incur costs themselves, paying for services from their own resources. Next slide, please. In terms of relationships, we've often worried about whether or not there are going to be enough adult children, for example, to provide care. Knowing that we cannot assume, because there are people out there, that care is going to be assured. And I think Mesha's presentation showed that very clearly. There's evidence that care disrupts family relationships with the person you're caring for, with your other family members, and that a history of family tensions can be exacerbated in the face of more care. Carers also can become socially isolated, making their own care more difficult. Next slide, please. One of the things that we see with subjective well-being of carers is that often we ask only about the care work they do. And so we see burden, stress, or anxiety, and often people feeling like they have no chance to opt out of care. We rarely ask carers whether or not they are able to live the kind of life they would like to lead. Next slide, please. With care workers, the evidence shows that they often have very low quality employment, poor wages, and uncertain income. These instabilities differ across categories of workers. We see, for example, that care workers who are community-based, as in home care, often now have contracts that are 0-hour contracts. We hire you, but we don't guarantee you any hours. Migrant care workers have particular concerns about precarious employment and their own immigration status. Live-in carers have risks of invisibility and then too many long working hours and often substandard working conditions. Next slide, please. For care workers, we have less understanding of their relationships or even which ones are important. And we know something about how relationships with the cared for person are seen as important, but often dependent on time, on relationships with the family, and can be difficult. There's more work being done on relationships with coworkers and supervisors, and the difficulties with disrespect and hostility in those relationships. We often don't ask about care workers' relationships with their own family members or with their social network. Next slide, please. In terms of their own subjective well-being, often we don't ask care workers. When we do, we ask them in relationship to their care work specifically. And what we see is that they're likely to be thinking about leaving their jobs, often though are feeling like they can't do that because of the trade-offs they make. Well, I have a job that's low paying, but I have poor qualifications, or my immigration status requires that I stay in employment. We know very little about carers' views of their ability to live the life that's important to them. Next slide, please. I think then the question that we must ask is, are there minimal acceptable levels of material and relational well-being for these workers? What can we really expect human beings to do and to continue to do? We need to, I think, look more closely at subjective well-being that Carers UK describes as having a life. Should I have to give up my life for this care work that I'm doing? We see some promise in rising interest in thinking about the care economy. That is broadly about paid labor and unpaid labor, and counting both in terms of how we understand sustainability. We need to think as well about who bears the cost. There are powerful themes of familialism around the world where there are untested assumptions about families who should take on the role of caring for one another. We see some of this even in the work that these care workers are doing, which is seen as work that women do, that it's caring work, and it should be done gladly and with less compensation than perhaps other kinds of work. I'm quite heartened by the work of the UN Decade of Healthy Aging, where they're talking about needing to look at well-being of individuals, of family members, and of communities. If we can really take that on in countries around the world, I think there might be some chance that carers would experience more well-being, and that we could soon be talking about the nature of sustainable care that we are now supporting. Final slide, please. Thanks very much, and I will look forward to our discussion at the end of this session. Thank you.
Thank you very much for the interesting paper on using the concept of well-being to analyze sustainable care from the standpoint of the informal carers. Now I would like to come to the next presentation, the final presentation, which will be given by Anna Ramos. Anna Ramos is a medical doctor. She's a researcher in the fields of healthy aging, preventive medicine, digital solutions, public health, geriatrics and ethics at the Anton Czernak Institute of Gerontology and Intergenerational Relations in Ljubljana. She's also working as a medical doctor at the University Medical Center in Ljubljana. So I would like to ask you now to start with your presentation.
Thank you for this introduction. As the last speaker, I would like to tell you a little bit about women and caregiving in Slovenia. And I will talk about their experience, or I could say other side of the experience. I will explain later why of informal care. So my co-researchers working on this are Aida Svetilšek, my colleague and psychologist, and Jože Ramos, head of institute and our senior researcher. What I'm going to present you now are preliminary results because the research was a little bit delayed due to COVID-19. And I would ask you for the first slide, please. So yes, before I really start, I would like to make a short disclaimer, because the woman and question of women and caregiving can be quite controversial. So this presentation and this research is not about the competition between men and women or about who is better or who provides better care. So at the Institute, we acknowledge that it's important for both men and women to provide care. We support gender equality. But at the same time, if I could ask for the next slide, thank you. We recognize there are differences between genders. I'm a medical doctor, so already from biological perspective, but also from psychological and other dimensions, there are some differences. And we are, in this research, we were curious about these differences and how they influence the care provision, or maybe reasons behind the care provisions, in order to, again, not to compete between different types of care provision or what is better, but to better support or to see this complementarity or to better understand it. And next slide, please. So what I'm going to tell you now is based on 3 types of research. So I'll shortly present all the research databases. The first we took research aging in Slovenia, needs, attitudes and abilities of people aged 50 plus. We carried this research in years 2010-2011. It's a national representative study with a quite huge sample that covered many areas, among them also caregiving and informal caregiving. Next slide, please. The next research we leaned on here was the evaluation and research study of informal carers training. So after each we provide also the Institute informal carers training, and after each training, people would be given a questionnaire with 26 items, and this questionnaire is made out of evaluation part and research part. And the questions in this research part are the same as those in representative study. So here we have a sample of 453 people. We collected them, is the best word, since 2010 to 2018, and they were picked up from 28 different trainings that were carried out in different parts of Slovenia. And then the third part of the research we did on the subject is qualitative interviews with informal carers. We started that in 2019 and it's still ongoing. Here we are doing more in-depth interviews with 10 women and 10 men. We are currently carrying out the interviews with men, so this part is not yet finished. Next slide, please. And now, because we cannot be all together, I would virtually invite you to Slovenia. So it's a small country in Central Europe, bordering the Balkan, and these are some impressions from Slovenia. Next slide, please. Because if we want to talk about caregiving, women and caregiving in Slovenia, we have to come a little bit closer. So first Slovenia, and then also situation of carers in Slovenia. If I would talk about that subject, I could tell you that we estimate that in Slovenia we have around 300,000 people, family and other informal carers providing care regularly. So that is that would be between 10 to 20% of our population in this case. So among them, we have 2/3 are female and 1/3 is male. When we looked back, this number was significantly higher for female caregivers, while it is changing now. So at the moment we are around 2/3 against 1/3, and in the future the projection shows that this number will come close to equal in around 25 years. So talking about this female group of carers, they provide care to their fathers, mothers, mother or father-in-law, to their spouse, to their brother or sister, a little bit less commonly to their son or daughter-in-law, to their grandchild, and in Slovenia quite frequently to their neighbors or someone else that would be friends and acquaintances. In the right column, you can see how many hours in average they provide this care for. But in average for all together, it would be around 10 hours per week, ranging from almost 24/7 down to just few hours per week. And to have an even better impression what these carers, informal carers, female informal carers do, is they provide all different types of care, from very simple chores, still very necessary, like shopping, small household chores. They might take charge of financial matters or housekeeping, down to actually taking care of activities of daily living, very basic ones such as personal hygiene, getting out of bed, helping them walk indoor, or to use a toilet, or feeding them. Next slide, please. And now I would go to our main research question, and why I said other side of the experience is because we often talk, and we also researched it, and it's very important, about the difficulties carers encounter while providing care. But what we want to look at here was actually the value of care this carers experience. And here at the slide you can see it's actually, we took the sample of the second research I mentioned, so informal carers training study, and in this sample there were 366 female women answering the question, what are the nice and positive memories associated with the times when you have been caring for ill, infirm, or frail person? And what came out, that was of course a qualitative question, and we did qualitative research. So we divided the answers into four main groups. The first group was related to the good memories to the caretaker. So here you will see on this picture, they mentioned caretakers' gratefulness was important to them, or they said, or a good memory, or caretaker's contentment, happiness, the fact that a caretaker could stay at home, didn't need to move to a nursing home, was also another subgroup here. And then something that was also positive, a good memory for them was also caretakers' kindness, patience, or courage. So these were subgroups in this category. Another category that came out was were good memories associated or related to oneself as a caregiver. So it was, you can see it's quite big in big letters here, personal contentment. So I was content that I doing that. Or I was personal joyfulness and happiness. Sentences related to personal good feeling, so having good feeling about it. Or feeling that I was useful, so usefulness. And then quite strongly it came out the investment into my own aging and my personal development as a good memory. And then third group was, we came out as good memories related to the care provision, so the process itself. And here there were two main subgroups. One was good and successful provision of care. So the fact that they were, a nice memory was that they could provide this care well. We also heard a little bit about that in one of the previous talks. The other one was that already the fact that I could help was important to them, or that they did something good and felt good about it. And the third subgroup was that they fulfilled an obligation, so this moral part. And then the fourth category, the main category, was good memories related to the relationship. So good relationship was important to them, or was one of the main nice or good memories they had. Why did we look at the good memories, and why do we link them with the value of care? As you look at the answers, you can see that what people actually talked about when asked about good memories or positive memories or about nice things, they actually talked about what was, at the same time, about what was important to them or what they valued. So, knowing also what the neuroscience nowadays confirms is that these parts are connected to the motivation. So what also gives you motivation, and something that also enables personal development. So from existential, so value not so much as a materialistic point of view, but more of this existential value that care provision has for these people. Next slide, please. And then when we compare that with our national representative sample, and in this sample we had 900 people answering to this question, and they were almost equally matched, men and women. Women, there was a little bit more women, a little bit over half, and a little bit less than half men. But it was interesting because some things seemed to stand out. Here at this point, I would remind you one more time, these are preliminary results, and we are still working on eliminating other factors. So you are to follow how that will look at the end. But what it seems now, that's the best I can tell you at the moment, is that for women, comparing to this whole sample of women and men together, it seems that the good memories related to caretaker seems to be more important, or they would mention them or notice them more, especially in all categories, especially in caretakers' gratefulness seems to be quite important, or something that strongly stayed in mind for them. And that would go well with also psychological concepts, a little bit maybe stereotypical for feminine attributes about care, about how one of the feminine attributes is care provision or caring in itself, and the concept of agency and communion the Bacon talked about. So about how maybe this communion aspect is a little bit more dominant among women, and so maybe more important in a way, or maybe they pay more attention to it as well due to that. While the good memories related to oneself and to the relationship are almost equal, as you can see, but when it comes to care provision, it's just the other way around. So the process of care provision, the fact that I could help, that I could provide help, or that the process went well, seems to be something that might be a little bit more typical for the male counterparts, but that's something that we're still researching. And with that, I would ask you for the next slide, please. At the end, I would like to illustrate what I was saying with the 2 sentences from the interviews I mentioned. And one of them is, we asked 62 years old female. If I remember correctly, she's providing care for around 10 to 15 years now to her mother. And she said, I think women provide care a bit differently, not better. My husband is great caretaker. But when caring for my mother, I will sing with her or scratch her back, pet her, and she likes it. We women notice such things. And the almost final slide, please. And another interviewee that we asked, so was 28 years old female. She provides care to her grandmother now for around 5 years, I think. And she said, for me, caregiving is giving back. My grandmother gave me so much and I came from her. She's my link to the past. Thinking about what is special about being a woman providing care, for one thing, a link between mother and daughter and grandmother and granddaughter is different. And maybe women are more intuitive, more sensitive to the needs that are not expressed verbally. So both these sentences would confirm a little bit what seems to be showing also from other data, but as I said, we'll know more about that when we come to the end of this research we are currently carrying out. But I would like to finish with a thought where I started. In a way, for us researchers and also us as maybe people who support carers or work with them in one way or another, I think it's very important then that in one hand, while we notice and research and help with the difficulties they have, which is very, very important, at the same time that we don't forget the value their work has and to recognize it as such. Their work, also things that they value and they find important. So as well as maybe specifics for women and men might have a part here as well. And it's something that we can build on so we can better support these people and so we can better understand the complementation of these 2 different genders and the things they bring to the table of caregiving. And the last slide, please. So I would one more time like to invite you that if you want to learn more about this research, that you follow our institute, or you can write directly to me. Here is my mail. And you're always welcome to Slovenia. Some of you might have already seen this picture in another presentation. It was not taken long ago here. So maybe we have occasion to meet in one time in the future. And with that, I would like to finish the presentation.
Okay. Thank you very much for this interesting presentation on psychological effects of informal caregiving based on the concept of value of care. Now I would like to come to the discussant of our session. would like to introduce Professor Matt Bennett. He will now give us some comments on the papers, and afterwards I will ask you to react on these comments and we'll start the discussion of all of the papers. I will first introduce you. Professor Matt Bennett is a professor research fellow at CIRCLE, the Center for International Research in Care, Labour and Equalities, I have to read it, at the University of Sheffield. His expertise is in inequalities and well-being outcomes of care and pro-social behavior, and his research is linking and analyzing large-scale surveys and administrative datasets. He is co-investigator in the research program Sustainable Care here, and she's leading together with Janet Fast the work package on care system costs and contributions. And I would like to ask you to start with your comments.
Great, thank you so much for the introduction. So first of all, I just would like to thank everyone in the session for such interesting presentations. It's really fascinating to read and to hear your presentations, and from a really broad and diverse set of countries as well. And some of the things that struck me were, a lot of the similar challenges that are being faced and opportunities that are being faced within different countries. I think as well, one of the things that I was I'm really taken by was in my introduction just then. I work mainly with large-scale social surveys, administrative data sets. I'm really interested in inequalities, particularly some of the inequalities and well-being outcomes that Nora highlighted in her presentation around relational, subjective well-being and material well-being outcomes. But often we really miss what's happening for carers or care workers. We see these big patterns. So in a previous presentation, I demonstrated that unpaid carers, informal carers, experience really negative impacts on their health in terms of what's called allostatic load. So we see that there are these patterns that unpaid carers receive or experience more chronic stress, but we really sort of miss the experience of carers throughout the life course. We miss the situations, how they're navigating, really complex systems. We really miss all of those elements and what's going on behind the scenes when we're looking at those large-scale population studies or analyses. So we really sort of heard a lot here today about health outcomes, gender differences, and pathways and trajectories into informal care, complexities in how people navigate the system. But also something that I'm going to reflect on a little bit more, or I would like everyone to reflect on a little bit more, is how we think about unmet need and service provision that results from change. Often people are receiving services, but those services, maybe are unsatisfactory. So what can we do about this when we're thinking about analysing, the quality of care provision, not only for families and unpaid carers, but also for care workers too. And then it sort of raised some challenges for me as well. Some of the things that I've been thinking about in terms of the data infrastructure. Lots of really interesting work here, but I've always been sort of struck by the sort of a lack of available data sources and where we might find and plug these gaps moving forward. So if I just would like to talk about Petra's work first, and I'm going to be raising some questions throughout this discussion that it'd be great if presenters could reflect on. So this is a really interesting study of Sweden. I know it was really interesting to me to hear your presentation because in many circumstances we see Sweden as a sort of exemplary country in terms of welfare state provision and the provision of lots of services. So to see that there are challenges in Sweden as well was really quite surprising for me. So that was interesting. You mentioned that some of the changes in the ageing in place policy has meant that the the provision of care and how care is experienced is unsatisfactory. And again, I was going back to my introductory comments, I was really sort of struck by what this sort of means in terms of how we think about unmet need and how we think about care poverty, how we better understand, that in people's lives. We also had, we heard about negative effects of health and well-being outcomes, which is something that I think Nora, summarised really well in her literature review. I think that this really helps us understand the experience and reasons that result in some of those outcomes. When we're thinking about the stresses and the pressures that people are under and just how they navigate these complex care systems. One of the questions I sort of had was, the study was pre-COVID and it was a longitudinal study, and I was wondering if you'd had an opportunity to follow up some of these people in your study to see what the impact of the pandemic has been for them. I was really struck by some of the work that we've been doing in the Sustainable Care Programme, talking to stakeholders and user groups, particularly informal carers, that some people describe the care support that they have as just being completely unsatisfactory, and it was really heartbreaking to hear that actually some reflected that the pandemic meant that some of those services were cut off, but that was actually that was seen as a positive because they felt that those services were so poor and insufficient. So I wondered if you could reflect on those points when we finish the discussion. Masha, moving on to your study, it was really interesting looking at your two countries and really sort of understanding and disentangling the complexities of why people, patterns of caregiving, really thinking, I think something that I've been thinking about is, really taking seriously the life course perspective and the cumulative advantage and disadvantage that results from many inequalities or many background characteristics. We don't necessarily experience these things in isolation. They're intersectional. We're experiencing at the same time, and as you say, experiencing these elements in the life course really has impacts on whether or not we care in the case of your study, but also other outcomes as well. So some of the outcomes that Nora discussed, and I guess I was really interested to hear about if you'd taken these transitions and you'd thought about what the well-being outcomes broadly defined might be, and what the impact on them might be. I think it's really important because you're really able to think about the family context, maybe the neighbourhood context, but how transitions at different points in the life course affect care, but maybe these other inequalities as well. It was also really interesting to hear about the intergenerational nature of being a carer or living in a household with with a carer. And I was wondering if some of your, if anything in your study showed what the impact of that was, maybe for children who have a family member as a carer who may be caring themselves, and how that changes the relationship between people. The other thing I was really interested in seeing is that you were really careful about conceptualizing your pathways, or these pathways emerged from the analyses. And I was wondering if you'd done any sort of mixed methods work, thinking about large-scale quantitative data, and how the pathways that you identify could help inform some quantitative studies looking at the same thing at a much sort of broader, larger scale analysis, and then linking that to some of the well-being outcomes that that Nora mentioned, but also vice versa. I wonder if you were doing any work that informed those pathways. So, if we take a broader scale picture, looking at the large scale data, if you were able to use the patterns and trajectories that you see in the large scale data to inform maybe sample selection and some of those analyses, rich qualitative analyses later on down the road. Moving then on to Nora's presentation, and this is work that has really sort of helped frame and conceptualise the sustainable care programme more generally when we think about wellbeing outcomes, and certainly in the work that I've been doing has helped us inform what our wellbeing outcomes are, and how we can better understand those wellbeing outcomes, what the causes of those outcomes are, and what the consequences are as well for unpaid carers. I think one of the challenges that I've had is in how we I think we know quite a lot about unpaid carers, and we have lots of great data, certainly in the UK and cross nationally on unpaid care. But the care workers is always something that it seems to be a missing piece of the puzzle. What well-being means for these people too. And I also think it's a really useful conceptual framework as well for when when we're thinking about sustainability, and almost helps us to think about a sort of preventative model of support and sustainability, and that's less reactive as we think about care systems. So moving on to Anna's work, really interesting work on gender differences, and this is something that we have focused on in the UK too. We see these really stark gender differences. In the UK, women are more likely to care. They're also much more likely to be carers at a younger age. So that they enter care 11 years earlier than men typically, and they're also more likely to be involved in higher care or higher intensity of care. And these things all have important consequences for people. Again, thinking about the well-being outcomes that Nora identified. If we just think about material well-being, having to care or being a woman who's having to exit the labour market, you're more likely to exit the labour market from full-time employment entirely, than to say necessarily drop your hours. So there are important implications here on income, but also pension contributions. Obviously, the erosion of social relationships as well, and increased social isolation. And this all is connected to well-being and health too, when we think about how people navigate the system, but the pressures and stresses that result out of care. So one of the things I was really interested in that context was really how, and I think this often gets ignored, is focusing on the reflections and the experiences of care in a positive light. I often think that that's missing from the literature. So that was really interesting. I guess I was really struck when I saw the presentation, how I was wondering if there was a clearer comparison you could make to the experiences of men. Clearly we had the women's reflection, but it would be useful maybe to think about the reflection of men too, and how that compares. I think that would be really useful to make inferences or comparisons between the two groups. And then secondly, you presented some really interesting findings in the quantitative data, and I was wondering if I could push you a little bit more to help us describe some of those gender differences between men and women. Some of them focused purely on female responses, or even in your comparison, you were comparing the general population and the representative survey to your much smaller sample of females in the primary data that you collected. And I wondered if you'd done any analysis where you restricted purely just to females, and what the differences might have been between those two groups, or if you were also able to compare to males as well. So those are my general reflections, and I wondered maybe if we could take each presenter one by one to reflect on any of those points, and then have a general discussion.
Okay, thank you very much for the interesting comments. I really would like to ask now the speakers to react but due to the time constraints, I would like to ask you to take only one point and to react perhaps 1 to 2 minutes, not longer, so that we have a little bit time left. I think we should start from the beginning because I had most time to reflect. So Petra Ulmanen, do you want to start? Just to react shortly on one point.
Yeah, thank you. Yeah, you asked me about the follow-up study. If I've been because my material was collected pre-COVID, and if I had the opportunity to do a follow-up study during the pandemic, and I haven't had that opportunity yet. Too much teaching, unfortunately, but I'm planning on doing it. But I think, well, in Sweden, you move into a nursing home very late because it's so hard to access them these days. So people live quite shortly after. They die quite shortly after. If you don't have suffer from dementia, maybe then you get in earlier. But I would like to do that, and I think that we have services have been cut off also in Sweden, Swedish eldercare. We have daycare centers that they just closed them, and home care services not being able to come, not having the right equipment the protective equipment and such things. So I think, it would be really interesting to do a follow-up study.
Okay,
Yeah.
shall we move
Do I have more
to
time?
No, we can move first to Masha and perhaps some time left. Yes?
Yes, thank you. Thank you very much for your comments. I think you raised very good points also about intersectionality and about the linking of quantity and quality, which is very relevant. I will pick up only one point on intergenerational that you've mentioned. So how you were surprised about this and how this might affect if you have an intergenerational household. And I think this is one particularity that where the differences between Austria and Slovenia were most striking, perhaps, because in Slovenia having intergenerational household is quite common, and it's much more common than elsewhere in Europe. It's more like the Southern and Eastern European way of living and offering also help to older parents through this living together. But we have seen, this has some positive and some negative effects. You were asking about the effects of caregiving on such life course, and we haven't studied this in this paper, but of course we have the data, and as far as I remember a bit, there were some positive effects on easier access to care, so it's less burdensome in a sense. But it does affect also family life. It stuck with me when one woman said that she offered that she put her father and mother-in-law first, then her children second, even though they were quite small and still needing her. But so we can see how this can have quite adverse effects, and I think this is a very relevant point of study that you raised.
Okay, so I would like to ask Nora to answer.
Thanks. Matt, I'd like to respond briefly to your question that you raised right at the beginning of your comments about how do we think about unmet need. And that's where I think the direction around understanding what makes up the components of well-being is really important. One might argue that because we've been so tightly connected to thinking about policy and public policy interventions, we're missing things like, I need to have time to be with my children, or I would like to be able to entertain my friends, or I'm severely lonely because of that. So I think we've been very focused on needs related to how you do your care job better. And there's been at least some new argument around, if you think about goals, how would you think differently? But I think the important piece is around some of these, whether we call them needs or goals, are not necessarily amenable to public policy intervention, but it doesn't mean they're not important. Or some may be amenable to public policy intervention, but it's in access to daycare for children, or it's in immigration policy, so it's outside of our focus around social care.
Okay, so I would like to ask Anna.
Yes, maybe briefly to answer your last two questions, is we are currently carrying out research about men. It's the same type of research for the male counterpart, so but it's not finished yet, so I couldn't present it. And when it comes to representative study, we are also because this was already done a few years ago, so I could just take this already done qualitative research data, but there are researchers now, my colleagues, they're working now on qualitative research, but we have to do it. So we have some results there already as well, because we had to divide it into two groups and do it again, basically. And it shows the same as that's why I was quite confident to show you the previous results. It's the same focus that that it seems that women are more attentive or more focused on the caretaker and caretaker related memories or things happening around the caretaker might be more important for them, while for men it might be the process that's more in the first line. And maybe finishing with what Nora was just saying, I was thinking that about unmet needs. It's continuing actually from that, not finishing definitely, but that we also have to think about what is already existing. So that's why I was talking today mainly about the positive memories and aspects, because that's something it's important to build on things that to really have in mind things that are unmet, but also to build from things that are already there, because bringing those two together, normally it's a realistic solution for people in the field. We also, in practice, we develop programs and work with these people. We have around 1,000 people, family carers in network that we interact with regularly. And especially when it's situations such as COVID, there are very strong unmet needs also due to the situation of epidemics, and they become even worse. But at the same time, if you can build from what is already there a strong point, it's something that's very protective for people, and they can bring from that. So maybe just to bring also that into discussion.
Okay, thank you very much. We have only 3 minutes left now for discussion in this session. So if someone wants to say something, otherwise I will wrap it up. Yes, someone?
I have a question. I have a question for Masha.
Yes, okay.
It was a very interesting presentation, and I thought it was very interesting about this, also both gender and also social class dimensions, about this one strategy or one pathway into caregiving was mostly by lower income persons, and another was used by higher income persons. And you didn't say any about disadvantages or negative consequences by caregiving by this like higher income group. Could you tell me something about gender and social class patterns in your material? And if the higher income group, do they like suffer any negative consequences at all?
We in this paper, thank you for the question. We haven't looked at these negative consequences, but for this study, we have collected how they cope with caregiving, and here there is less difference, kind of, and I think it relates to what Nora was saying about well-being. So we see in both that well-being may suffer regardless of the pathway into care, because but coping strategies might be different, and possibilities might be different, but we haven't yet have time to really look into that and these differences. But I think that what Nora emphasized in this unmet need and well-being, this is why it's important to look at care from the dyadic perspective. I think looking both at the carer and the caregiver and both of their needs, because if you just take one part, you can see the transfer of unmet needs and the problems that are transferred to the other person giving the care, and detrimental effects on them. So I think this is very important what we discussed today.
Yeah, further comment?
Yes, I guess what I've seen, I think it's been a really interesting session too. And one of the things that I see that I think is promising for us moving forward is looking at these intersectionalities that we've been talking about, gender, SES, and so on, looking at them over time. And, and that's some of the work Mesha talked about and that I've been working on as well, which is how do these play out? What if your carer that you're looking at has been a carer for the last 15 years? How is that different than if they're newly come to care in the middle of their life and they've left their job? Those kinds of intersectionalities, layering in the processes of care, I think could be hugely important. I think some of our data sets would allow us to look at those in the large scale. I'm a great fan of projects that have large scale data analysis and then the qualitative pieces that get us at so what does this all mean for people? So I think it's lovely work, and I'm looking forward to coming to visit all of you sometime. Thank you.
You're welcome.
Very nice final word, I think. Before this now time is over, I would like to thank all presenters, all speakers, and all the discussants for the very interesting session. And I think we have looked at informal care from very different angles and perspectives and situations. And I think we can have also made a good contribution to discussion. What is sustainable home care? Which was actually our starting question when I started to arrange or to define these 4 sessions. I think it was very interesting. So thank you very much.
Thank you.